professor in pharmacology and in medicine. She, I could go all day telling you about how great she is, but in summary, she has she's internationally known and renowned in the area of pharmacogenomics, not only on the discovery side. She has a large NIH-funded research program in pharmacogenetics discovery that's been funded by the PGRN, but then also on the clinical implementation side has an IGNITE-funded research program around pharmacogenomics. And today she'll be telling us at least about some of that. So I'm delighted to have her here, and I hope you have a chance to meet with her individually if you can after the talk. So thank you for being here.
So thanks for the opportunity to be here and tell you a little bit about what we're doing at University of Florida in pharmacogenomics implementation. So many of you may have been really excited in 2015 when the president highlighted the Precision Medicine Initiative as a major program of the federal government to move things forward. It's not always that the president talks about the thing that you do, and so I'm sure, like me, for many people in the room, that was an exciting moment. And many of you also know that program is getting ready for its official launch, and they've changed the name of the program to All of Us. And the concept is to really build a very large data set that tries to figure out how we use individual information, which includes sort of biology, genetics maybe being the most obvious of those biological markers, but also information on environment and lifestyle to really advance more personalized approaches to care. So I think, most people in this room understand that precision medicine is likely to be a really important future element of medicine. And many people would argue that the concepts aren't new. Many people feel that, we've long really taken a personalized approach to the care of patients, but these are just allowing us to use new tools. And clearly genetics is an important part of that. And within genetics, I would argue that pharmacogenetics is currently the most actionable and the space where we really can do the most at present. So what is the concept, or what are the arguments around pharmacogenetics? So this is a cartoon that actually Bill Evans and I created for a review article that we wrote, I think, in 2001, and I feel like it still works today. And so the concept is that we take people who have a given diagnosis, and historically we have either treated them with the same protocol of drugs, or we have sort of a trial and error approach. So cancer, for example, you have a given diagnosis. Historically, patients with a given diagnosis, breast cancer, colon cancer, we get the same therapy. Cancer is clearly at the forefront now of using genetic information, particularly the tumor genome, to help really not call that a single diagnosis, but really refine that diagnosis and then influence therapy. There are other diseases like hypertension, diabetes, depression, where there are lots of choices, but we tend to use a trial and error approach in selecting drug therapy. The reality is that in that group of patients, there are actually at least 3 cohorts. There are people who are going to have the desired response to the selected drug therapy. There are going to be people who do not respond to therapy. And then there are going to be people who have toxicity. The toxicities really generally come in one of 2 flavors. The first is drug concentration-related toxicities, where a lower dose may help prevent that toxicity, or toxicities that aren't related to dose and a different drug is needed. And so the reality is that in most situations, we figure out which of these 3 categories a patient falls into by giving them the drug and seeing what happens. And the concept is, can we figure that out using genetic information or genetics plus a lot of other things to, in an a priori sort of way, predict where they belong. If they fall into this group and they're predicted to have good response without toxicity, then we go ahead and use that drug. If they would be predicted to have a poor response, then we do something different. And if they're predicted to have toxicity, depending on whether it's a pharmacokinetic issue, we might decrease the dose, or if it's not related to pharmacokinetics, use a different drug. And so that's really broadly the concept And so, you know, how do we advance that? And Deepak mentioned that we really tried to be involved in this whole spectrum. So first is really discovery of the genetic variants that might influence drug response. And we've done a lot of work in that area, particularly with cardiovascular drugs. I'm not going to talk about that at all today. Once you have those discovery elements in place and you have well-replicated genetic association, then you have to think about developing tools for using that in the clinical setting and really figuring out if the associations are robust enough to be predictive in the clinical setting. So you can have genetic associations, but they may not be strong enough to actually be useful in the clinical setting. And we've done a lot of work with that, particularly with warfarin and the International Warfarin Pharmacogenetics Consortium. Again, I'm not going to really talk about that. Then there's the clinical implementation, and I've talked with a number of people today, and that's really trying to figure out what are the logistical barriers, what is the evidence base that you need for clinicians to actually use this information in the clinical setting. How do you build it into the EHR? How do you figure out, you know, all the things with sample transfer and the pathology lab? And so that's a lot of what the IGNITE network has really been focused on in the first cycle. But I think ultimately, and IGNITE in the next iteration is really going to be focused more on this latter bullet, which is how do you document that there are impacts on the clinical outcomes? Because without that, ultimately, it doesn't matter if you can implement in the clinical setting. If it doesn't change anything, then it's not really going to be of value over the long term. And this is probably actually the most important for two groups. For the physicians and other prescribers who are going to use that information in the clinical setting, ultimately they're going to want this level of evidence. And additionally, for payers who would be asked to pay for the genetic test, they clearly need those kind of data. So I'm really going to focus primarily on data for this last bullet. So one of my pieces of evidence that pharmacogenetics is sort of among the most implementable is just really looking at the IGNITE network. So there are 6 of us funded in the IGNITE network, and I have 3 of them in red, and they're in red because we are all funded to do a pharmacogenetics-based project. These other 3 also have active programs in pharmacogenetics. So all of the programs funded in IGNITE, whether their primary funded effort or secondary efforts, are doing work in pharmacogenetics. We also have, I think, 17 affiliate members in the IGNITE network, and at least 16 of the 17, their primary focus is in pharmacogenetics. So clearly there's a lot of energy in the IGNITE network around pharmacogenomics. And so for those of you who aren't familiar, the IGNITE network has a website and toolbox, which we actually host at the University of Florida. So check out our website if you haven't seen that. As it relates to implementation of pharmacogenetics, the CPIC guidelines have been really helpful and I think have helped to drive implementation of pharmacogenetics. So CPIC stands for the Clinical Pharmacogenetics Implementation Consortium. There are currently guidelines for 34 drugs, and this does not include any cancer therapies where it would involve somatic mutation. So there are some cancer drugs in this list, but it's called germline variation recommendation. And this is the website for CPIC, which contains all of these guidelines. And then also, if you're not familiar with PharmGKB, which is the pharmacogenomics knowledge base, which really curates the pharmacogenomics literature, has all of these guidelines, but it really is an excellent source of additional information about pharmacogenetics.
Can I ask a quick question?
Sure.
Do you view CPIC as the guidelines that should be used to make a decision about implementation, or guidelines that should be made be used for clinical use? In other words, in your paradigm, it sounds like there's an evidentiary threshold that you need to get to decide to actually implement, but actually to create large-scale, large amounts of evidence, scaling up to large trials like IGNITE is going to do is sort of the clinical use.
Yeah, so CPIC probably is, most of the CPIC guidelines are probably mostly at there's sufficient evidence to implement. You know, there are not always, and in most cases for the CPIC guidelines, there aren't sort of hard clinical outcomes data. That clinical implementation of this use case leads to differences in outcomes. actually, if you have a pyramid, it really probably in most cases is there's sufficient evidence that warrants that, that you can safely implement in clinical practice, and, and that there's some evidence that it would be clinically beneficial, but not always sort of that evidence that says in an implementation in clinical practice we have evidence. So, good question, though. And so I'm going to really focus on two of our clinical implementations and really just try to tell you stories around those where, really our first goal was to implement into clinical practice and document that we could do that, document that we would get buy-in from the physicians, that we could kind of figure out all of the logistics. But what I really want to focus on are the outcomes data that have arisen from those, which again, we think ultimately is sort of most compelling for advancing the case for pharmacogenetics in practice. So first I'll tell you about CYP2C19 and clopidogrel, which is our original implementation, and then I'll share with you some data from a study that we recently completed with CYP2D6 guided opioid therapy. So just as background, so we're all on the same page, CYP2C19 is a drug metabolizing enzyme that has a very common genetic variation. So a very common allele, which is called STAR2, which leads to a loss of function due to a slight site variation and truncation of the functional protein. Less common is a STAR3 variation, but also leads to loss of function. And then some very rare other alleles that lead to loss of function. And then also a very common promoter region polymorphism that leads to increased expression of the protein and really a gain of function. And so we collapse these different genotypes into a group of phenotypes for drug metabolism. So STAR1 is sort of the default, if you will, normal allele. So people who carry two STAR1 alleles are called normal metabolizers. People with one loss of function allele are intermediate metabolizers. Two loss of function alleles have no functional protein, no ability to metabolize through this enzyme, and those are called poor metabolizers. One of the gain of function alleles called rapid metabolizers, and two gain of function alleles called ultra-rapid metabolizers. So as it relates to clopidogrel, clopidogrel is what we call a prodrug, meaning that the molecular compound that is ingested by the patient does not have pharmacological activity. It has to be bioactivated. So there's an inactivation pathway, and about 75 to 85% of the drug is actually inactivated, but then there's a two-step activation pathway to the active metabolite, which is shown here. So interesting, as it relates to clopidogrel, it was known when the drug was approved for marketing by the FDA that it was a prodrug, but there wasn't a good understanding of the enzymes that were involved in the bioactivation. And so then it was really later discovered that these are probably the enzymes involved in the activation, but CYP2C19 is an important enzyme in both the first and the second activation pathway. So I mentioned that the STAR2 allele is common. About 30% of whites and blacks carry a STAR2 allele, meaning that at least they have intermediate metabolizer status, and up to 70% of Asians carry at least one loss of function allele. So a high percent of the population has sort of a reduced ability to metabolize via this enzyme. So what does that mean for clopidogrel? So I think you can see that if you have reduced or absent metabolism through CYP2C19, then you are going to generate less of the active metabolite. If you generate less of the active metabolite, it's probably not going to work as well. And so in fact, there is a lot of evidence documenting that those who carry the STAR2 or any loss of function allele have less of the active metabolite in their blood. They have reduced antiplatelet activity in terms of the pharmacological effect. And then retrospective analyses of randomized controlled trials show that people who carry the loss of function allele who have undergone a percutaneous coronary intervention have an increased risk of MACE, or major adverse cardiovascular events, which in most studies means death, heart attack, and stroke. And so there are CPIC guidelines. One of the first sets of CPIC guidelines was for clopidogrel, originally written, I think, in 2010 and then updated in 2013. And so these are basically the CPIC guideline recommendations. So in patients with acute coronary syndrome and or PCI, when CYP2D6 genotype data are available, if they carry one or two loss of function alleles, so IMs or PMs, the recommendation is to use alternative therapy rather than clopidogrel. In those who are normal metabolizers or who carry the gain of function allele, clopidogrel is a reasonable therapy choice for them. So we launched our implementation program in June of 2012. Took us almost a year to really sort of prepare in terms of the infrastructure for that. So we launched in June of 2012. So we've been live for almost 6 years. And this is just a picture of the cardiology's website on the day that we launched that program. So we really believe that an important element of any clinical implementation is a clinical decision support. So at UF, we are on EPIC. And so this is what our best practice advisories look like. So they really are yellow, and it's to create sort of a caution. We've worked very closely with our pharmacy team at Shands Hospital to be very careful that we do not trigger a best practice advisory unless we have a concrete recommendation. So we will never trigger a BPA based on pharmacogenetics that says monitor closely or use with caution. That's not a recommendation. We don't want to make the mistake that I think everybody would agree has happened with drug interactions, where there are so many drug interaction alerts, some of which are trivial, some of which are very important, and the very important ones get missed because the vast majority are trivial. So we have very clear recommendations. So this is what our CYP2D6 clopidogrel looks like, and this is really sort of the basic format that we use for all of them. So we have one sentence that describes what the problem is. So it says the patient's CYP2D6 genotype is associated with impaired metabolic activation of the prodrug clopidogrel and elevated risk for stent thrombosis or other cardiovascular events after PCI. Then we have one sentence that kind of walks through the pharmacology behind that, and then we have specific recommendations, prasugrel or ticagrelor. We remind the clinician of what the contraindications and cautions are for those two drugs. And then at the bottom, they can actually, so this would trigger when the patient has an IM or PM phenotype, so they carry a loss of function allele and a prescription for clopidogrel. So both of those things have to happen. And then the clinician would choose whether they want to instead order prasugrel, so that would actually cancel the order for clopidogrel and then initiate an order for prasugrel or ticagrelor, or they want to continue with clopidogrel. And if they continue with clopidogrel, we just ask them to sort of explain why they're doing that. So two other things that I'll highlight. One is that the genotype is reported here. There's also a traditional pathology report that has the genotype and how it was done and all of that. This is very minimal because in our mind, we don't think it's important for the cardiologist in this case to know what the genotype is. We just want to empower them with the information to know what to do. So we give it to them, but we're not making a big deal about it. If they really want to know more information, we have a link that links them to the literature that supports these recommendations. And we haven't looked in a while, but after we had been live for about a year, so this had never been, nobody had ever used this link. So I think really reinforcing that a busy clinician, they just want to know what to do. And we spent a lot of time with our cardiology team, and I think they were comfortable and they understood the evidence behind it. But really that just give them clear guidance, and that's what they're looking for.
Question? Sorry if I missed this. If you go back, what was the acknowledge reason and exclamation mark and search thing in that middle, between, just below the yellow?
Oh, so I think this is the if they choose this, then this opens up for them to type in the reason.
Okay. Why they're staying.
Why they're staying with clopidogrel.
Okay.
Yeah.
And if the genotype is not available, do you actually offer people who order clopidogrel the opportunity to get genotype?
So we haven't done that with clopidogrel. We did do that for the thiopurine. So if a thiopurine is ordered and they don't have a phenotype or genotype, we make the suggestion that they consider that. But we didn't do it for clopidogrel because we are not really making recommendations outside the PCI setting, and we thought it would create a lot of confusion in sort of those other uses of clopidogrel. So we didn't build that for clopidogrel.
So how are you identifying patients with the genotype? If you're approaching them to have the genotype done.
So this implementation was totally a clinical implementation. There was no research-informed consent. And so it was added to the post-PCI order set. So it was sort of pre-selected on the post-PCI order set. When we originally started, we had it on the pre-PCI order set. And that's when the grant was paying for the genotype. And so basically anybody coming to the cath lab was getting a genotype. When we stopped paying and we sort of truly made it clinical and we started billing, if the insurance company didn't pay, and in most cases they did, but it became concerning if we had somebody who didn't end up getting a PCI, didn't end up on clopidogrel, and then was getting billed for this test. And so at that point, the cardiologists weren't comfortable anymore doing it at the pre-cath setting. So we then moved it to the post-PCI order set.
So the patient doesn't know that they're getting this done?
It's just part of,
they're having blood work done, so they're not getting
and so we had a lot of conversations with our ethicists about that. And, at the end of the day, the feeling was that, if the cardiologists agree that they consider this a reasonable part of standard of care, I mean, we don't consent patients for every single thing that they do. They consent to care. So they consent to care when they get a PCI, and then that's just sort of part of their care. So it did take some conversations for everybody to get comfortable that we weren't consenting them for a genetic test. But I think in the end, the feeling was, this is just a clinical laboratory test, and the physician is choosing to use that clinical laboratory test to help guide decisions. Is it really different than a serum creatinine to help guide dosing or to help understand their renal function? Which I think is the right, I think there have been, especially in pharmacogenetics, it's like there's this genetic exceptionalism. It's really just another laboratory test that can help guide decisions about therapy.
With coming up with the recommendation, how do you guys go through that process? Is it based on things from CPIC, or do you have a panel of folks that contribute to?
Yeah, both. And so when we started this, the first CPIC guideline was out. And so in general, we have done implementations where there are CPIC guidelines, although we did implement PPI recently, and there's not a CPIC guideline yet, although there is one in the works. So it's really both. So we look at the CPIC guidelines, but then we pull together a group of experts, which includes sort of people from our pharmacogenetics group, the relevant physician group, so in this case, the interventional cardiologist, people from hospital pharmacy. Early on, we actually ran this through the hospital's pharmacy and therapeutics committee, and so all of this was eventually approved by that group. Eventually, they sort of said, we maybe don't need to do that. And it got complicated as we started doing outpatient interventions because our P&T committee only has jurisdiction over inpatient formulary. And so we eventually moved away from that. But we do for every one that we implement, as we build these, we have sort of an expert panel that we pull together to come to agreement on what the language is and are we comfortable with the evidence and that kind of thing. Okay, so we published our data from our first year. And so again, in our first year, we were doing everybody who was having a left heart cath for suspicion of coronary disease. So if people were having to have a left heart cath because they were getting a transplant, a liver transplant or something, those people we did a genotype, but pretty much everybody else. So we had a little over, or about 1,100 patients with a genotype reported into their medical record in that first year. About 300 of them had a PCI, so nearly all of them had a genetic test. Nearly all the PCI patients had a genetic test. We did see an uptake in use over the first year, so this is our use in the first 2 months, and then in the last 2 months. And we were really, we were pretty aggressive about encouraging them to order a test, so I'm not going to suggest to you that this all just sort of happened organically. And then when we look at the actionable genotypes, so those who carried at least one loss-of-function allele, there were 80 patients. All of the PMs, they changed the drug, so they did not use clopidogrel, which was really the standard drug in this setting. I think ticagrelor may have been approved in this first year that we launched. And then about 2/3 of patients who had one loss-of-function allele had their drug therapy changed. So, we felt really successful implementation. We figured out the barriers. The physicians adopted it. They made changes in therapy based on the genetic information. And again,
patients long-term beyond this?
What's that?
Do you follow this cohort?
So yeah, so we've got the long-term follow-up data. I'll show you. So just to again highlight the frequency of these polymorphisms. So and this is a little bit later. This is at into our second year, 408 patients at that point. 31% carried a loss-of-function allele, which really fits our population. We don't have a lot of Asians in the Gainesville area. And at that point, 54% were getting alternative therapy. And again, at that point, ticagrelor was pretty new, so mostly prasugrel. And I'm not going to really talk about it, but important in a lot of other settings, including with PPIs, SSRIs, is the gain of function, which I've sort of collapsed to both the heterozygotes and homozygotes, but also 30% of the population, which means that only 40% of the population are normal metabolizers. So the vast majority of patients either have sort of elevated metabolism capacity or reduced metabolism capacity through this enzyme. So we're like, okay, that's great. We successfully implemented. Does it really matter clinically? And so we looked at that 2-year mark at our outcomes data in patients who were genotyped. And so these are the individuals who had a loss-of-function allele and got alternative therapy. So this again it says survival, it's actually MACE, so death, stroke, and MI. So these are our loss-of-function allele patients who got alternative therapy. These are the patients with loss-of-function allele who did not get alternative therapy. So they were continued on clopidogrel. So they did significantly worse as compared to those who got alternative. These are the people who didn't get loss-of-function, didn't have a loss-of-function allele, and were treated with clopidogrel. So we thought that was great. Cardiologists are a skeptical group, and so said, well, that's nice, but maybe there's something weird about Florida. And maybe there is something weird about Florida, but so then we really took this into the IGNITE group to see if we could see the same sort of thing and have a larger sample size. But our data clearly suggested that a genotype-guided approach would reduce the rates of death, heart attack, and stroke. So then within the IGNITE network, funded groups as well as affiliate members, we pulled together data from 7 academic medical centers who had implemented in a very similar way that we had. So we had nearly 2,000 individuals in this data. Again, 31% carried a loss-of-function allele. Among those with a loss-of-function allele, we had clopidogrel use continued in 40%, 60% got alternative therapy. In those without a loss-of-function allele, alternative therapy was much less common, so these were significantly different. Again, really proving that it was the genotype that was guiding the use of that alternative therapy to a high degree. So again, really showing that at a national level, the information can be and will be used to change the drug therapy decision. Again, and this is partly timing, but the majority of the alternative therapy were with prasugrel. So these are the outcomes data. These were published as an EPUB, I think, late in December and published just a couple weeks ago in JACC Cardiovascular Intervention. So just like our data, now these are an event curve rather than a survival curve. Again, MACE, so death, stroke, and MI. In the patients who had loss of function with clopidogrel, they did significantly worse than the loss of function patients who got alternative therapy. Those patients who did not have a loss of function allele and got clopidogrel did not do differently than the loss of function alternative. So there are questions about, well, is clopidogrel just an inferior drug to prasugrel with ticagrelor? So our data, although it looks like they did a little bit better, not significantly different. So, so this was not a randomized controlled trial, and so we did propensity scoring to try to match and control to the extent that we could, and then calculated hazard ratios. And so in that adjusted analysis, if we look at loss of function who got clopidogrel versus loss of function alternative, a little over a twofold increased risk of major adverse cardiovascular events. So suggesting if they have a loss of function allele and you go ahead and use clopidogrel, you're probably doubling the risk of an adverse outcome. No difference in loss of function carriers with alternative therapy, prasugrel or ticagrelor, versus non-loss of function. So again, we feel like now at a national level across multiple centers have documented the same thing that we saw at UF, which is that a genotype-guided approach to antiplatelet therapy when clopidogrel might be used can help improve cardiovascular outcomes.
Question, where was did you look at the fourth curve, the non-loss of function alt? And where was
the non-loss, we did, again, it was only 15%, so it was a tiny number, but it was basically pretty much superimposed on the, yeah.
It looks like most of the events are occurring in the first month or so.
Yep.
And so have you looked at what would happen, at least using these data, in terms of the events if you switch people from the alternative drug to clopidogrel at, let's say, month 2, so you can reduce the cost of overall therapy?
Yeah, so it's an excellent point, and you'll see that, indeed, most of the events are occurring in the first month, and definitely mostly in the first 2 months. And this is a diagnosis where the health system won't get paid for that readmission in the first 30 days. And so we've done economic analyses also out of the IGNITE network, and it really suggests that that a genotype-guided approach with clopidogrel is sort of the way to go. There has been a definite shift toward the use of ticagrelor as the primary therapy, and so we've implemented at our hospital in Jacksonville. They weren't far enough along to be included in this data set, but that's exactly the plan that we're really working on with them, is ticagrelor in everybody for the first month, genotype during the first month, and then at the end of the first month, switch to clopidogrel in those who don't carry a loss of function allele and continue ticagrelor. So, and I think all of those things are modeled in the economic analysis a month, and so, we think that may be, in some ways, the most logical approach, because one of the challenges here is the turnaround time for the genotype. If you have a loss of function allele, and you don't have a rapid turnaround genotype, so Spartan Rx, and we've actually done that in our CAS lab at Jacksonville, but there are challenges with it too. You can get the genotype result back in about an hour, but the sample has to be run within an hour, and if you don't have pathology, if the person has an MI in the middle of the night and there's not a pathology person there to run it. And so from a logistical perspective, the month of ticagrelor, which gives you a month to get the genotype, we feel like also sort of works better than having to wait a few days into therapy and then change their drug. So to summarize this part of the story, so we have data across 7 institutions with almost 2,000 patients, documenting that clinical implementation in multiple settings is feasible, that cardiologists will use the genetic information to change their antiplatelet therapy decisions, and perhaps most importantly, that the data suggests that a genotype-guided approach will improve outcomes for those patients.
Can I ask a question about that last point? You have there that it produces it, but you said suggests. So is this sufficient evidence to say you should be doing this?
So,
if not, what is
so this is the debate in the cardiology community. So the editorial that went with our paper would say we still need a randomized controlled trial. I think that's a personal decision that cardiologists and patients would have to make. I personally wouldn't have me or anybody in my family take clopidogrel if they carried a loss of function allele. If I was an interventional cardiologist, I don't think I would use that drug without that information. But, you know, many cardiologists are sort of very rigid and say we need randomized controlled trial evidence, and, you know, if that's your bar, that's not what we have.
Is
So
that trial launched yet?
So those trials are ongoing. Mayo has been leading a trial called Taylor PCI. It launched about the time we launched our program, like 2011, and their trial completion date continues to get pushed back. So the last I saw was 2020 they were going to complete. So I think it's just really, and I think for all of pharmacogenetics, I think the question is, you know, we will never get anywhere if every question has to be answered with a randomized controlled trial. And so we have to figure out as a healthcare community, and it's not just with pharmacogenetics, I mean, our system can't afford to answer every clinical question we have with a randomized clinical trial. And, you know, so this makes sense, like all the pieces of evidence line up, right? If you believe the pharmacology lines up. The drug concentrations are lower, the antiplatelet activity is lower, the retrospective clinical trial data support this, now prospective implementation trials support it. For me personally, I have no idea why you would say we still have to have a randomized controlled trial to prove this is true. But I accept that there are people who disagree with that. So I say it reduces. The editorial that goes with our paper would say this is very strong suggestive evidence. If that answers your question. So, and I'm going to transition. So if there's any more questions about clopidogrel, we'll do them now. Okay. So the next one I want to talk about is CYP2D6, another drug metabolizing enzyme with common loss of function variation. In this case, there are several alleles. Star 5 is a deletion allele. Star 3 and 4 are loss of function mutation. Star 4 is a premature stop codon. This is a really, many people consider this, next to HLA, maybe one of the most complex genes in the human genome. So it also has duplication or multiplication. In the literature, there's one case in the literature with 17 copies of CYP2D6, so an interesting and unusual gene. So much like CYP2 C19, we collapse these genotypes into phenotypes to make it a little easier to interpret. So we have normal metabolizers, meaning they have, if you will, normal ability to metabolize through that enzyme. Intermediate metabolizers, in this case, in most centers, is defined as one reduced function allele. There's also a whole bunch of polymorphisms that reduce the enzyme activity but don't lead to loss of function. So reduced function plus loss of function we call intermediate metabolizer. Two loss of function alleles is poor metabolizer. And then ultra-metabolizers are those who have a duplication or multiplication of functional alleles, so they have at least 3 copies of the CYP2D6 gene. Again, pretty common in the population. So poor metabolizers are among white, Asian, and African ancestry individuals, 5 to 10% of the population. Some rare sort of smaller populations where much more common. Intermediate metabolizers, sort of a similar percent of the population. 1 to 2% of the population have these duplications that lead to excessive metabolism through the pathway. So somewhere around 80–85% of the population has a genotype that makes them normal. So it's about 15 to 20% not normal. The other thing that is really important about CYP2D6 is there are a lot of really clinically important drug interactions with CYP2D6. And so CYP2D6 inhibitors have been characterized as strong or moderate. Strong inhibitors, fluoxetine is one example, basically phenoconvert somebody to a poor metabolizer. So they basically wipe out the function of that enzyme. And then moderate inhibitors are estimated to reduce activity to about half. So So there's an interesting story, and this cartoon is shown for codeine, which, because of the issues with CYP2D6, is much, much less commonly used. It's basically now completely contraindicated in all children. But the pathway is relevant for other commonly used opioids. So basically, these are also drugs that need to be bioactivated. In the case of codeine and tramadol, tramadol has about 50 million prescriptions a year, so really commonly used in the U.S. So they are inactive, so they also are prodrugs and have to be bioactivated, and the only bioactivation pathway is through CYP2D6. In the case of codeine, it gets activated to morphine, and tramadol gets metabolized to, I think, 4-hydroxy tramadol. And then further metabolized. These are basically inactivation pathways. These are not active. And so in a poor metabolizer, there's somebody who does not have active CYP2D6 enzyme, there is no ability to activate the drug. You can get, with codeine and tramadol in a poor metabolizer, no analgesic effect. There's no ability to generate the active constituent. A little bit different than clopidogrel, where there's still some, because there's multiple enzymes, no ability for codeine and tramadol. In the case of hydrocodone and oxycodone, as the parent compounds, they do have some analgesic activity, but they also have very, very potent metabolites that also have to go through CYP2D6 for activation. So, so there are CPIC guidelines. I thought I took this slide out. No. So there are CPIC guidelines for codeine and tramadol with softer recommendations for oxycodone. Let me back up just 1 second. So the flip of this is the ultrametabolizers with a normal dose of codeine generate an excessive amount of morphine. And there have been deaths, particularly in children, due to respiratory depression because the child, or in one case, the breastfeeding mother, was an ultrametabolizer. So problems at both ends. So these are the CPIC guidelines, and again, we have really 4 metabolizer groups. So the ultra-rapid metabolizers, the recommendation would be to avoid codeine and tramadol because of the potential for excessive generation of the active metabolite. In extensive or normal metabolizers, these drugs are fine. In intermediate and poor metabolizers, they recommend sort of caution for the intermediate metabolizers. In our program, we actually recommend avoiding in intermediate and poor metabolizers and using a drug that's not metabolized, using an opioid that's not metabolized through the CYP2D6 pathway. So in this case, rather than sort of a pure clinical implementation like we did with clopidogrel, we did a pragmatic trial, and we enrolled 480 primary care patients with chronic pain defined as at least 3 months of pain. So we randomized patients 2-to-1 to a genotype-guided versus a usual care approach. We did patient-reported outcome measures of pain and some other things used in the NIH-developed PROMISE measures. And just to give you an idea of the sort of the severity of the pain, the baseline median pain score was 6.7 out of 10. So we, again, tested for CYP2D6, reported that into the electronic health record. A little more complex because you have to do SNP testing, but you also have to test for deletion or duplication. So a little bit more complicated genetic test. That turnaround time on average was about 7 days. We also considered strong and moderate CYP2D6 inhibitors to define the CYP2D6 phenotype. So we looked at both the genetic information and the enzyme inhibitors. We have a PGY2 residency in pharmacogenomics, and so our PGY2 resident provided a consult note on everybody who came back with a CYP2D6 genotype and made specific recommendations in ultrametabolizers, that's all genetically based, and then poor metabolizers and intermediate metabolizers, again, looking at genotype and drug interaction. And then the note was sort of written into the chart, and it was really the request of our physicians to take this approach as opposed to a traditional clinical decision support. Again, it was a little more complicated because of the drug interactions, although we're working on building a more automated approach. But then it was up to them on whether or not they wanted to use that information.
So I'm sorry, can I ask So everyone who got the genotype done got a consult?
Correct.
So then the physician had to find that consult, or?
So they would have to see the consult, right? And so I'll talk to you about some of the problems with this in a second, because having it in front of the physician at the right time is an important part of the plan. And so this just gives you an idea of what we ended up with. So poor metabolizers by genotype was 5.2% of the population. When we also consider drug interactions, over 18% of the cohort. Intermediate metabolizers also 5% when we consider drug interactions. So you can see about 32.5% we consider to be intermediate or poor metabolizers when we consider genotype and drug interactions. The ultra-rapid metabolism phenotype, and it says normal to ultra-rapid because right now in our laboratory, they don't define which allele is duplicated or multiplied. They just know that there is an allele. And so sometimes we're not positive whether they're ultra-rapid, but we sort of code them this way. So again, about when we consider genotype and drug interactions, about 60% that are normal metabolism where we wouldn't recommend anything different. And so, you know, just to highlight, drug interactions, pheno-converted about 22% of our patients to intermediate and poor metabolizers. And so we think, particularly for this gene, taking into account drug interactions is really important. So these are our pain data. So our primary hypothesis is that in patients who are IM or PM with tramadol and codeine, where we know that they need the CYP2D6 enzymes to bioactivate, these are our pain data. And so just to orient you to the graph, so we have the genotype-guided in black and the usual prescribing in gray. And then we have pain scales on the least amount of pain they had in the last 7 days, the pain they're experiencing now, the worst pain in the last 7 days, what they would describe as their average pain, and then we have a composite. We created a composite score, which is now worst and average. And so what you can see is that for all of these, except for worst and average pain, but in our composite and least and now pain, we had significant improvements in pain in the genotype-guided versus the usual care group. In pain studies, many studies use, and for the FDA for approval of a drug for pain, you have to show a 30% reduction in pain. So when we looked at the percent of patients, so recognize these are patients who had at least 3 months of chronic pain, so sort of tough individuals in terms of pain management. 23% of our genotype-guided patients had at least a 30% improvement in their pain score. None of the patients in the control group had a 30% improvement. Again, suggesting that we can improve pain outcomes with a genotype-guided approach. So we presented these data at our last Ignite meeting, and so one of the questions from our program officer, which is a little intimidating, was, well, maybe it's just that they knew they had a genotype, and pain is a little bit subjective, and so maybe they just thought they were doing better because they had a genotype. So the way that we're proving it's not a placebo effect is we looked in our normal metabolizers because we would not expect them to have pain improvement. And indeed, in none of the measures was pain significantly different between the genotype-guided or the usual prescribing. So again, suggesting that it really is the actions that were taken based on the genotype that led to the improved pain control.
Did the patients know the results of the genotype?
They did not know the results. Well, they could know the results, but, I mean, we didn't sort of explicitly give them results, but they knew that they were being genotyped. And they knew that that was going to be used by the physician to think about and potentially help improve their therapy. So there was a potential placebo effect, but we don't see that.
I mean, if they read the CPIC guidelines and they knew their genotype, then they wouldn't expect the result, a better pain outcome.
Right. Well, So that's all theoretically possible. We didn't hand them their genotype. I mean, through the MyChart portal, they could have looked it up. Our patients probably aren't, on average, that sophisticated, but that would be possible. But when we looked at the percent that had 30% pain reduction, it was identical in our genotype-guided patients versus control. So it doesn't look like that's what we're seeing is a placebo effect. Because of the literature is sort of more vague about hydrocodone and oxycodone, we then looked separately at hydrocodone and oxycodone, and the trends with hydrocodone looked basically exactly like the codeine tramadol data. So these are the data now with tramadol codeine and hydrocodone, again in IMs and PMs, and really the same thing that we saw. So we think for these three drugs that the CYP2D6 genotype is important. On the other hand, for oxycodone, we really see no evidence of a genetic effect. So our trial's probably not large enough to dismiss that CYP2D6 is important for oxycodone, but unlike what we see with tramadol codeine and hydrocodone, we don't see that at all for oxycodone. So we need to understand a little better what's going on there, but right now we're really focused on, in our future implementations, we're really focused on these as really our targets. So again, just to convince ourselves that, that this was due to changes that were made in therapy, when we look at patients, and we genotyped everybody, when we look at patients who had an actionable genotype, in the implementation arm, we had significant difference in changes in drug therapy in the actionable versus non-actionable, no differences in the control group. When we looked at whether or not there were dose changes, because we were not recommending dose changes, we were recommending drug changes, and there were no differences. So we did not expect differences here, and there were no differences in dose changes between implementation and control. So this is really sort of coming to your question. When we recommended changes, how often was it followed within the 3 months of our study period? And it was followed 31% of the time. So in almost 70% of the patients where we recommended a change, the change wasn't made. Why is that? Well, the reason we think is because of when the information was available to them relative to their sort of interaction and care of the patient. When they did make a change, how often did they follow our instructions? Nearly always. So what this tells us is that a 7-day delay in getting the genotype in front of the physician is a problem, right? Because many patients are not seen again for another 3 months. So the physicians may act on the genotype, but they're not going to act on it until they see the patient again. And so, one of the challenges that we're trying to figure out how to overcome is, or that we think is really critical, because clearly when they had that information and they made a change, they basically always followed our recommendations. They just didn't have the information at the right point in the patient care process. And I think one of the things that we have learned in all of our implementations is you cannot walk into this and expect that the physician or clinician group will change their sort of practice flow, right? And it's not normal practice to call up a pain patient 7 days later and change their prescription. And so getting it in front of them in time when they're interacting with the patient, we think is critically important. And so we're really trying to figure out how to do that. So again, in a primary care setting with a completely different kind of patient, with a more subjective phenotype, we showed that clinical implementation is feasible. We think the data suggests we can improve pain control, but we really have to figure out how to get the genotype in front of the physician at the time of that physician-patient encounter. When we do that, there is strong adherence to our recommendations. And we think really critically important to consider drug interactions and genotype, not just genotype in the case of this particular drug. So again, we had about 10% IMs and PMs based on genotype only, about 30% with genotype plus drug interactions. So one of our next steps with the pain initiative, so UF in collaboration with our Clinical and Translational Science Institute is to go to the health system and say, where are really the problems in the health system, and then the CTSI tries to sort of match that with investigators. And so, as I'm sure is true in every health system at the moment, there are a lot of concerns about pain management and opioid prescribing. And there are also data that post-surgical opioid use is probably a really important contributor to opioid addiction. So there was a study published earlier this year in JAMA Surgery showing that in outpatient surgical procedures, 6% of patients have persistent opioid use at 6 months. And they estimated just based on outpatient surgical procedures, that's 2 million new opioid persistent users per year. That doesn't count inpatient surgical procedures where there's probably more intense pain use. And so we are working with our orthopedic surgery group. We hope to launch in May genotype-guided therapy for our orthopedic surgery patients. And so this is an example where there really is a great opportunity to get that genotype in front, and will really allow us to prove whether the genotype in front of the physician at the right time makes a difference. So for orthopedic surgery patients, there are typically 2 visits before surgery, one where there's a decision made to do surgery, and then Medicare requirements say that they must have a preoperative visit within 30 days of surgery. So the plan is, on the visit where the decision for surgery is made, we will order the genotype. We'll also consent them, because we're going to do this also as a pragmatic trial. And then we have a fairly long window to get the genotype result back, so that when they have their pre-op, their true pre-op visit, where labs are ordered and all those things are done, and when their prescription for their opioid is handed to them, because it's a Schedule II drug typically, and it has to be a paper prescription, that the genotype information will be there. So we think it's really kind of this perfect scenario to have preemptive genotyping. We have agreement with the surgery group that tramadol will be the preferred first-line therapy in patients who have normal metabolism phenotype. Again, trying to reduce use of Schedule II opioids. And so, our goal is to have better pain control because you're using the right drug, but we think that there may be a secondary benefit of reduced use of Schedule II opioids. And in our state, our legislature is considering a law that would strictly limit the use of Schedule II opioids. And so, this may help make things easier for them as well. So we're anxious to see, because I think this will allow us to prove whether that information at the right time makes as big a difference as we think it will. And then we also, I think, those of us in pharmacogenetics research believe that panel-based testing is the way to go, not one gene at a time. And so what we did in our health system is we looked at all of the patients who had a prescription for tramadol, codeine, or hydrocodone, and then in the following year, how many of them had a prescription for one of the other drugs where there's a CPIC guideline. And so these are just some examples. So UF Health Shands is the hospital in Gainesville. UF Health Jacksonville is in Jacksonville. And so you can see similar trends, a little bit differences in use patterns, but you can see that these are very common. And so 65% of our patients who got tramadol, hydrocodone, or codeine in the following year had a non-cancer CPIC drug. So really, I think highlighting that the downstream potential use if you have data on multiple genes is very, very high, because these are all really, really commonly used drugs in healthcare. So again, we think arguing for panel-based testing, which frankly is a bit of a challenge with payers, but again, we have to just continue to build that evidence. So what are some of our lessons learned from our implementations? I think we've really clearly documented that physicians and other prescribers will use genotype data to guide their drug therapy decisions. But we really feel that the other thing we've learned is it really has to be in front of them at the time of the physician-patient encounter. Because otherwise it interrupts the workflow and it's just going to be less effective. We have to provide clear guidance on how to interpret the genotype data. So whether that's a clinical decision support or a consult type note, but it's very clear that if we just sort of provide the genotype data, that the average clinician is not really going to know what to do with that, nor should they. We also have really seen just phenomenal enthusiasm from patients. They are really excited. Our pain patients were really happy to participate. And on our control group patients, we contacted them after they had completed the study to see if they wanted their genotype done. And I think it was like 96% wanted their genotype done and reported into their medical record. The other thing is when we've done these pragmatic trial approaches where there's a control group who won't have the genotype up front, really both the physicians and our sense is the patients wouldn't agree to participate if they weren't going to get the genotype eventually. And so there really, I think there's a lot of enthusiasm from patients for the information. And then, you know, from my last slide, in patients with chronic diseases, they are going to end up on multiple what we would call CPIC drugs, or drugs that pharmacogenetic implementation is reasonable. So to conclude, you know, we think we are continuing to build good evidence that genotype-guided approaches can improve clinical outcomes. I showed you our data on post-PCI patients with clopidogrel and CYP2D6 with pain. We also have some interesting emerging data with PPIs that we think also will begin to build a case there. But we have to continue to build that evidence for clinical outcomes. We think it's really critical, A, for physicians and other prescribers to really fully buy into the use of the information. And perhaps our biggest challenge is payers, and that payers really need that evidence level to be willing to support. So this is a team effort, and these are just a few people involved in this effort. And we've, of course, been really fortunate to be funded well. Initially, we had funding through our PGRN grant to get some of these things started as what was called the TPP project and the PGRN. And then a lot of support from our CTSA award and our CTSI, which is the institute that the CTSA is funded in, as well as our NIH grant. And with that, I'll thank you and see if there's any other questions.
Thanks, Julie. I wanted to ask you just briefly, I know we're over, but can you talk a little bit about physician or healthcare provider education and engagement in this process?
Yeah. So every time we have done an implementation, we have been sort of very, I would say, aggressive about getting in front of the physician group or clinician group. In our PPI implementation, one of the main users was a PA, for example. So it's not always physicians, of course. And so we have, in most scenarios, we have taken a strategy of offering genotype testing to them so that we can give their genotype back to them. And we do a research lab genotype because it's much less expensive than doing it through the clinical lab. But we felt like that really helps to allow them to internalize it at some level and enhance the engagement. And so that's a pretty standard approach that we have taken. And so, you know, we go in and we have really very targeted education. So if we're trying to implement for pain, we're not talking about pharmacogenetics generally. We're not talking about, you know, SSRIs and PPIs, like we're trying to implement in pain, and so we focus on the pain literature. And so, you know, we feel like in general that has been a successful approach. We also have a conference that we do every March, and this year we're offering CME, and so we're hoping that, you know, as we've sort of built interest and energy, that we'll get more and more engagement across the state.
Great. Any other questions?
So I'm guessing that you sat down with your local payer community and presented them all this data. What are they looking for before they establish coverage?
Yeah, so, you know, it's really interesting. Our head of ACA, which is our Medicaid program, was on campus just in mid-December. And And, you know, it seems that if we sit down and show the evidence, they're going to be willing to cover. I think the challenges are actually in some ways more the private payers, and trying to figure out, because there's so many of them, and trying to figure out what they're looking for. So.
Who's worse, payers or cardiologists?
I think the
Well,
payers.
with that,
I think the payers are tougher.
We have to answer that. Thanks, Julie.